we'll pick those up at the end.
Okay, good afternoon, everyone. I'm Herman from the Garden Route District, and I've been asked to introduce our guest speaker, Mark Heywood. We've met more than 30 years ago in 1990. I was a medical student then, and I did my elective in Alexandra Township in Johannesburg. And that year, Saddam Hussein in Iraq invaded Kuwait. And I was invited to a sheikh in Alex to watch a movie, and it was Lawrence of Arabia, which was a surreal experience to see this epic movie in this township sheikh. And it was to educate us about the colonial history of the Middle East. And Mark was there and I was there, we met there. We were both part of an international Marxist organization. We worked together until 94 when our ways parted. But then in 1998, in the meantime, Mark was working for the AIDS Law Project and put a human rights slant onto the response to HIV in South Africa and internationally. And in 1998, when the Treatment Action Campaign was founded, Mark was one of the founding members. And I pretty soon after joined the Treatment Action Campaign as the Western Cape coordinator, and him being on the national executive, we managed to collaborate quite a lot. And him being a very good strategist, good spokesperson for the Treatment Action Campaign, I think did wonderful work to put HIV activism onto the map. And he was involved in getting fluconazole, the big pharmaceutical companies like Pfizer, to basically give up their patent. He managed to run the court case as the AIDS Law Project to get government to commit to a PMTCT program to get pregnant mothers to get nevirapine at that stage as a first step. He was involved in the court cases against GlaxoSmithKline and Boehringer to get the patents fought on the ARVs, which resulted in a price reduction from 4,000 rands a month per person to 50 rands a month per person. And this campaign to reduce ARVs to about 1% of their original cost made it possible for ARVs to be distributed throughout Africa, saving millions and millions of lives. When in 2006, the government rolled out the treatment program for ARVs, the AIDS Law Project decided to diversify to address other needs in the Constitution, the basic human rights, including education, and it became Section 27, where he was the director of. As Section 27, they spearheaded the campaign for justice for the families of the people who passed away in the Isidimeni life tragedy. And spearheading that and bringing that campaign to a good outcome. He then left the Section 27 and is now presently working with the Daily Maverick as the editor of Community Maverick. On a personal level, I think Mark is a father of 2 sons. Before those 2 sons, he had 2 very difficult pregnancies. The first baby was diagnosed with hydrocephalus and it ended in a stillbirth. The second pregnancy, his wife had a rupture of the scar of her uterus, and it was an Easter weekend. They struggled getting a doctor, they struggled getting an anesthetist, and while the baby was removed by cesarean section, it was a stillbirth. So this was quite a traumatic experience, I think, in his life, and putting equity on healthcare, in a personal level into his life. I think he's always stood up for human rights, justice, and access to treatment. So it's a pleasure to introduce you, Mark, to hear what you've got to say about the inequity of our healthcare system. Thank you.
Thank you very much, Herman, for that introduction. I wish we could leave it at that point. But yeah, thank you to everybody for the invitation to speak to this very important rural health conference. I felt very nervous to say yes, and I felt even more nervous since then, because I realize I'm the person who knows the least about rural health, but you're asking me to be a keynote speaker on rural health. So I hope that in the discussion that follows and in the course of the next 2 days, that any errors of understanding that I make, that you will correct. But also, I'm hoping in this presentation to provoke you all to think deeply, not that I'm suggesting you don't think deeply about the steps that we need to take at this moment in time to revive and restore a vision of equity in rural health, because I think that as a country, we have lost that vision, and we have to perhaps begin by admitting that. I also want to thank you, before I start with my comments, just for the roles that you have played as healthcare workers in the past 15 months, and of course, before the advent of COVID. I don't think enough credit or recognition is given or understanding to the sacrifices or efforts that you have made, to the ways that you have innovated, the ways that you have fought to save lives and to restore health. A few days ago, I was interviewing the Minister of Health, and I asked him for the numbers of healthcare workers who have died of COVID-19. And a couple of days later, he told me that 1,297 healthcare workers have died of COVID-19 in the course of duty. I think that that number is probably an underestimate, but nonetheless, it reflects an enormous sacrifice. What it doesn't reflect is the efforts to protect life. The official statistics in this country at the moment of COVID-19 deaths are, I think, at 78,000. But as you know, that is the official recorded COVID-19 related deaths. The number of excess deaths due to COVID-19, or the number of excess deaths from May of 2020, will in the next few days top 250,000. And that is not a model, it's not a mathematical calculation. Those excess death numbers are based upon tabulations of medical certificates on death. And healthcare workers have borne the brunt of managing those deaths, and I believe at tremendous cost to your own peace of mind and mental health of many healthcare workers. So it would be remiss of me to start this presentation without saying thank you to those of you who are here, those of you who are online, but also to all healthcare workers for your contributions that you have made. Now, getting into the substance of what I wanted to say at this meeting today, I want to start just by saying that I think as we discuss rural health equity, one thing that we must always remember is that the idea of equality in health, of rural health equity, is not wishful thinking. Health equity is prescribed in the supreme law of South Africa, in our constitution. Our constitution says in section 27 that everyone has a right of access to healthcare services, everyone. It doesn't say everyone in urban areas or everyone on medical aids has a right of access to healthcare services. It says everyone. And it doesn't stop at that. It goes further and says that the state must take reasonable legislative and other measures to progressively realize that right within available resources. So the state is bound to oversee continual progress towards universal health coverage, towards equity in health. There's another aspect to the Constitution about equity which people often overlook, which is that Section 27 is followed by Section 28 on children's rights. And when it comes to children, one of the things the Constitution says, and remember this applies to about 30 million people in our country are under the age of 18, that every child has a right to basic healthcare services. Now, there's a difference between Section 27 and Section 28, which is that Section 28 doesn't talk about progressive realization within available resources, etc., etc. It creates a duty on the state as soon as possible to ensure that all children have basic healthcare services. It's called what we call an immediately realizable right. Now, that is relevant to rural healthcare because many of the people that you care for are children. And the reason that I'm saying it is that I'm sure if I was to ask you in a discussion about the quality of healthcare for children with disabilities, very few of you would respond by saying that children in our district, in our hospital, have all of their basic healthcare needs met, that we are able to provide those children with basic healthcare services. So we mustn't forget that framework, and we mustn't give up on that framework. And I think that what troubled me as I started to prepare for today's presentation is that it is quite clear that not only are we not progressing towards equity in relation to rural health, but there are certain signs that we may be regressing as we move towards equity in rural health. And if that is the case, then I think it requires a very serious introspection by us as health activists and as health practitioners. It requires us to rethink our strategies. It requires us as RHC or whatever, NURESA, PACASA, are we being heard? Are we banging this drum loud enough? If we're banging the drum loudly, are we being heard? Or people got used to our drumbeat and they've learned how to ignore that drumbeat. So, but I had to test that thesis. So because I'm not a rural doctor or rural nurse, I spent a few days consulting with doctors and nurses and healthcare workers working in the field to find out from people what their experiences, what their own views of things were. And I want to start, and I want to relay some of those experiences, but I want to start with the positives. I want to say categorically that equity in rural health is possible. It's important to state that. This is not an impossible ask. It is possible to create equity and equality in rural health, and there are instances where that has happened in hospitals or in districts or in particular communities. So we're not holding up something that is a dream. Even in our context, in our environment, in the midst of generalized poverty and inequality and broken systems, equity is possible. rural health matters. And what struck me is that, and many of them come from yourselves, that there are many centers of excellence for rural health provision. And we have to give credit to RHC and others, because it is often through your work that we can talk about those centers of excellence. But I think that the problem is that those centers of excellence are due with what me in my old Marxist life would have called subjective conditions rather than objective conditions. It's to do with the subjective efforts of healthcare workers, of a particular clinical manager, of a particular ethic that exists in a hospital or a clinic, rather than to do with the system. In fact, those centers of excellence exist in spite of the system, rather than because the system aids excellence, aids equity in rural healthcare. And therefore, the problem is not a problem to do with the healthcare workers, for the most part. The problem is a problem to do with the healthcare bureaucrats, managers, system, politicians. And I'm going to be blunt in this meeting. Like I said, I'm not as acquainted with rural healthcare as I should be, but just to give you a non-rural example, I spent a few hours interviewing the head of trauma, the head of acute surgery, the head of the COVID response at Chris Hani Baragwanath Hospital a few weeks ago. And it was very clear, you know, Chris Hani Baragwanath Hospital has dealt with this massive tsunami, and they've dealt with it effectively. But every innovation that took place, every modification of systems to make it possible to manage that tsunami came from the clinicians and from the nurses and from the people within the hospital. None of it came from the provincial health department. Now, I don't want to tar every provincial health department, every health manager with the same brush, but I do want to make the point. The point I'm trying to make is, one, health equity is possible. Second, there are centers of excellence. But thirdly, the system is not helping us to realize that. Now, I don't have time to talk too much about either the strengths or the weaknesses, but just to give you some examples, and Lungi in her presentation and other people talked about wins, talked about some of the inspiring innovations. But, you know, just with the challenges of vaccine rollout, you know, here in Limpopo, it's set an example. MEC Ramatuba deserves commending for the rollout of the vaccine program. Although, again, I have to say it is a lot to do with the foot soldiers on the front lines of the healthcare system. But there's one facility, Glovo Medical Center, many of you know, they vaccinated 60,000 people at that medical center. There are parts of the Eastern Cape. I chatted to people linked to the Bulungula incubator, talking about the fact that they think that they're getting 95% coverage of over 60s because they've gone out and they've taken healthcare to the people. I talked to the team that has been working with Jane Simmons, the Go team that took the initiative of taking vaccinations to people in queues waiting for social grants, initially at 14 sites throughout the country, and found that they were able to vaccinate similar amounts of people every day in the queues to the numbers of people who were coming to clinics, found that more men were willing to be vaccinated in queues for social grants than traditionally men come to healthcare services, et cetera, et cetera. So there is excellence and there is outcomes, but how do we make the system work? Because the bottom line, and you're welcome to disagree with me, this is my conclusion, is that overall inequalities in access are widening and outcomes are worsening. Perhaps not across the board, but in certain disease areas. And I'll illustrate both. On the question of inequalities in access widening, I spoke to clinical managers in Limpopo, in the Free State, in the Eastern Cape, in Northwest. And if I had time to go through my speech, or if I was clever and had overheads, I'd be able to show you what they said. But everybody says, yes, access has improved. But although access has improved, there are issues with quality. There are issues with supply of medicines. There are issues with supply of medical devices. And there are particular areas of medicine where there is a huge gulf between rural and urban. You know, I spoke to the clinical manager at Diflabeng Hospital in the Free State. You know, he identified emergency medical services, eye care, mammogram, cardiology, mental health care, neonatal care, arthroplasties as areas where the gap is very, very wide. People raised issues of being understaffed, under-resourced. People raised the underfinancing of the health system. That is inequity, and it's systemic inequity because the system which should be working to facilitate equity is either by omission or by commission not providing that equity. And I think that's where we need to focus. Now, when it comes to outcomes, I think, you know, you only need to look as far as what has happened with sorry, and the last thing before talking about inequalities, you know, we heard MEC Ramatuba today talking about Limpopo, but I think the day when activists and politicians reach the same conclusions about the state of healthcare services, then we'll know that something is happening. Because, you know, in this province, the Treatment Action Campaign and several other organizations of people living with HIV, they have a program called RHC2021. And what it does is it goes to clinics, and they're going to hundreds of clinics throughout the country. And they assess clinics against a set of benchmarks based upon the perceptions of people in those clinics. And the survey they've just completed in Limpopo, 94% of facility managers say their facilities don't have enough staff. 5.58 hours, the average reported waiting time by patients. 51% of patients felt very unsafe waiting for the clinic to open. 38% of patients left the clinic without medicines they needed because of a stockout or shortage. Now, TAC has done a survey of the urban centers. I didn't have a time to compare whether the findings in Gauteng or the Western Cape are similar, but this is inequity, this is inequality, this is unacceptable. But as I said, coming to what outcomes tell us about equality and equity, you just need to look at COVID-19 outcomes. Again, we don't pay enough attention to it, but every week the MRC publishes its excess deaths report. And just looking at this most recent excess death reports, the death rate in the Eastern Cape per 100,000 versus Gauteng and Limpopo, for me, tells you a great deal. In Gauteng, the death rate per 100,000 people is 345. In the Eastern Cape, the death rate per 100,000 people is 593. In Limpopo, the death rate per 100,000 people is 437. Now that is, for me, that is the story of inequality and lack of equity in healthcare systems. And behind those numbers, well, you know the stories behind those numbers better than I do. So that, for me, is the state of the rural health nation. Still unequal, possibly getting more unequal. Some centers of excellence unable to meet, for reasons given by some of the speakers before, the colleague from the nurses, Tabisa and Gaza, no additional budget, no additional staff, etc., unable to meet these waves. And one of the things I'm going to say to us all is that COVID-19 is a harbinger of things to come, not just of things to of health threats to come, not just of viral pandemics, but of other issues. And so we're not looking at health equity as if we have a stable platform that will just stand still while we tinker and fiddle with it and try to create it. We have to try to create equity in the face of a growing series of health threats. But what went wrong? Let me speak to that for a couple of minutes. There's no doubt that the intentions were good. The Constitution, as I said, sets out the intention. I had a look at the 1997 white paper for the transformation of the health system in South Africa. Worth everybody to go back to. Wonderful language about equity, about community healthcare workers, about building the healthcare system from primary healthcare upwards, et cetera, et cetera. The human resource plans of the last 25 years, the equitable share formula for budgeting, which is meant to make sure that you provide extra money to provinces that face greater education, greater deprivation, et cetera, with a view to remedying historical inequalities. The intentions were good, but despite the intentions, the outcomes have had no relationship to the intentions. So I think the question we have to ask is why? Why has this happened? And there, the answer that I came to, how do we understand this crisis, is that rural health and the objective of health equity has suffered a series of what you might call exogenous external shocks. They may not have anything directly to do with rural health, but they impact on the provision of rural healthcare services. And so, and I raise this because in South Africa, we like to live and work and think in silos. So we talk about corruption and state capture, as if corruption and state capture is one thing and healthcare equity is another thing. And yet, corruption and state capture, I think, are an exogenous shock that impacts on the healthcare system and that impacts particularly on the weakest parts of the healthcare system by disorganizing health, by taking resources away from health. You know, a few years ago, 2012, in fact, we tried to calculate what corruption costs the healthcare system every year. In 2012, we worked out it was about 20 billion rand a year. That was the size of the ARV program. Probably corruption costs the healthcare system today twice that. Let's say 40 or 50 billion rand a year. Now, each of you knows how you struggle for financial resources, whether it's for devices, for rural rehab, whether it's for medicines, whether it's for staffing, whether it's for rehabilitating a clinic. Money that gets stolen creates a shock, a wave that hits things like the healthcare system. HIV was an exogenous shock to the healthcare system. We tend to not talk about HIV these days as if it's past, but you just have to think what the healthcare system had to do to respond to that. Governance of provincial healthcare systems is a shock to the healthcare system. Again, it goes back to my points about system management. Almost every provincial healthcare system is chaotically organized, to put it bluntly. You know, in the Free State, speaking to the people at Ditlabeng Hospital, one day they wake up and they get a memo, no warning, the budget is being cut by 300 million rand. We have to cut the budget by 300 million rand. You can no longer do 1, 2, 3, 4, 5. And it's not just cuts to complex healthcare services. It's cuts often to even the most basics, whether and how you can purchase bandages, etc., etc., etc. And finally, there is the effect of declining per capita budgets, declining budgets for health. I'm going to speak a little bit about the Health and Human Resource Plan in a few minutes. But I think you all have to know that in this period of austerity budgeting, health is being cut. So the idea that we can put ourselves onto a path towards equity is somewhat dreamlike in the context of declining budgets. So those are the shocks that have hit rural health. I would suggest that future shocks are likely. We haven't discussed, and it's not on your program as far as I can see, the shock that the climate crisis is going to give to healthcare systems in the next decade and beyond. I know Garrett Branwell has done a PhD on the climate crisis and mental health. But if you look at the sixth intergovernmental panel on climate change, the report of the scientists that was published 2 weeks ago, climate heating is going to take place at twice the rate in Southern Africa as it is in many other parts of the world. And that is going to be a health shock. It's going to put further pressure on rural healthcare services whilst you have less resources. And I'm sorry, I'm not trying to depress you with these things, but I am trying, I think Steve Reed calls it critical realism. But there are new shocks in the wings. So all of this means that in some ways, we find ourselves running to stand still rather than to get ahead. So as I come to a conclusion, what I really want to challenge you with is to say, as Sanele said from Pakasa, this conference has to be a turning point of some sort in the way that we think and strategize around rural health. It has to be, as far as I'm concerned, the kind of reckoning with the realities that we are facing, and then a questioning as to whether the strategies that we are adopting are going to be sufficient to meet the realities. So let me finish by saying what is to be done. First, what is not to be done? No more investigations. No more consultants to investigate this and that and so on. We know basically what is going on, and we know essentially what the problems. We have policy in place that ought to be sufficient to take us towards an objective of equity. In October last year, you see lots of paper. The National Health Council approved Human Resources for Health Strategy 2030. Now, this is a very important document for rural health because its objective is equity in access to human resources. It says, for example, that significant additional investment in health workforce will be required to improve health service access, quality, and equity. Improving interprovincial equity in the public sector by 2025 will require an additional 97,000 health workers, with community healthcare workers comprising around 1/3, etc., etc. Very important document put together by many of our best minds in health in South Africa. The problem is that since this document was passed, nothing has been done. again. 1 year almost since this plan was adopted, it hasn't even been looked at, basically. Now, people in government could say, well, we've had the COVID crisis, but the COVID crisis should be reason to speed up attention and implementation of a human resource plan, not to neglect it for another year. When I asked the Minister of Health a few days ago about this plan, his answer for me was a non-answer. It was like more of the same about inequalities and the problems of the cost of the occupation-specific dispensation, etc. They are real issues, of course, but if you pay enough attention to them, you can get beyond them and you can make a plan. Poppy Ramatuba recognized the importance of community healthcare workers, and yet we're still really at an impasse. I mean, I think about community healthcare workers and I think about AIDS conferences of a decade ago where we were hammering on the importance of community healthcare workers. The calculations have been done about how many community healthcare workers are necessary. We know that community healthcare workers would be budget and cost saving to the healthcare system. They would save the government money if they were employed and if they were trained properly. And yet we still don't have a proper cadre of trained community healthcare workers. So if you're thinking about what is to be done, I think one of the advocacy challenges is to try to put this human resource plan squarely back onto the government's agenda and not to let go until there is an implementation plan and a budget that is linked to this. And the same can be said of other policies. Mareka showed me the 2017, what's the name of the policy? The white paper on disability. We have policies that have been passed on palliative care and healthcare services, which haven't been touched for half a decade or for longer. We have to insist to government that you don't set up another ministerial action committee, another task team, another this or that, unless there's a commitment that whatever comes out of these processes is actually going to be implemented and is actually going to be budgeted for. So we have the policies in place, and I could spend longer, but I need to wrap up. More concretely, what can be done? I've identified really here issues under 3 headings: health services, social determinants of health, and then the state of our own organizations and rural health activism. Under health services, I think that we have to build on best practices from below, but expand their reach and influence. It is going to be something that we face in every sphere of life in the decades ahead. If we don't rebuild from below, it's not going to happen from above. Yeah. So many of you come and work in hospitals that despite everything work very well. How can we ensure that those best practices spread out to clinics, to nearby hospitals, et cetera, et cetera? How do we ensure better health advocacy and information? Public health messaging is absolutely critical at this time, but it's absolutely woeful. It's no surprise that we have vaccine misinformation is taking such a hold, because there's nothing to counter it. There's no serious system that puts out on a continual basis in all the languages we speak in this country, scientific, popular, accessible, sensible information that people can work with. We know when that happens that it works. The Treatment Action Campaign helped to pioneer the idea of treatment literacy around antiretrovirals. Remember, there was denialism around antiretrovirals. There was misinformation. You'll die, you'll be poisoned, you shouldn't take this and this and this. But we have 5 million people on antiretroviral treatment because of the approach that we took to public health information around ARVs. We need to spend everything that's necessary to create health literacy and health understanding, because it will make your jobs so much easier if the people who come to you have some prior understanding of their health, their bodies, what it is that poses a threat to them, what they should drink, what they should eat, what a baby requires, etc., etc. That isn't asking too much. The third thing under health services is taking health to the people. And I've given the examples of the Limpopo vaccine program, the pioneering of vaccinations in grant queues, etc., etc. And the last thing that I would say under health services is integrating health into communities, not keeping health separate from our communities. Now, these things to you are bread and butter. I understand. I'm not telling you something you don't understand already. But the question is, what are the pillars that we say health systems must be rebuilt around? What are the pillars that the national health insurance system, etc., must be built around? Because NHI must concentrate on quality. It's not just a question of coverage. It's quality and access and accessibility of healthcare services that's the critical thing. On the social determinants, I would say that health professionals have to adopt a position on key policy and social justice questions. And I'm going to go over this very, very quickly. There's a debate going on at the moment about the need for a basic income grant. The only way we are going to mitigate poverty that comes with mass 75% unemployment areas, 75% youth unemployment, is through something like a basic income grant. And I think that you as healthcare workers have to understand the debates about a basic income grant, so that when some clever treasurer, minister of finance, tells you that it will just create dependency, you're able to explain that actually that's nonsense. And there's no basis on which it will create dependency, and that ultimately a basic income grant may be generating of income and economy rather than something that is just regarded as a drain on the fiscus. I think you have to pay very close attention to early childhood development as healthcare workers. I've been doing quite a lot of research recently on ECD, and it just strikes me how critical it is to all aspects of health, but how neglected early childhood development is, and how nobody is really paying attention to what has happened to children, to the shocks that children have undergone in the course of COVID-19, and what the implications of that are for the future. So I think there has to be a social justice agenda if we're going to get close to equity in rural healthcare. And then the final thing I just wanted to say, and I won't make any comments on this, is just, I think we have to debate the state of rural health activism again. What is working and what is not working, because just continuing to do the same will not deliver, and we will keep coming back to these conferences year after year and complaining. It's time to take stock of each of our organizations and of the strategies of those organizations, and to refocus on strategy. It's a problem, for example, I'll just give one example. It's a problem that we don't have a rural health movement. Why is it that we don't have a rural health movement? The biggest rural health movement in the country is the Treatment Action Campaign, but it doesn't understand rural health. It has about 150 branches located in predominantly rural provinces, but it's not working on rural health. How do we combine your knowledge, your advocacy, your understanding, your framing of rural health with the way organizations like the TAC act? It's not easy, and it won't be quick, and it'll be frustrating at times. But if you don't do it, it's never going to happen. So I've been told 2 minutes left, and I promised I'd only speak for 25 minutes, and I've probably spoken for longer. In conclusion, what to say? More of the same won't do. Number one, I've said that. Number two, probability is that there is going to be increasing inequality. And increasing inequality means increasing inequity. Number three, the state has a serious challenge with its own capability and capacity to do anything at the moment. And therefore, just relying advocacy that just says, we demand, without doing and showing and building, and where necessary, putting capacity into the state, will not be successful. We have to capture the government for the people. We have to capture government for healthcare services and healthcare rights. Have to identify key pressure points for rural health. Rural health needs to be much more in the air, it needs to be much more in the media, it needs to be much more in the public domain. I'm lucky these days, I'm a newspaper editor. And as I was listening to the 4 presentations that came before me, there's so many important stories there that people will identify with, that people will resonate with, and that will help people to understand, including politicians and decision makers, what the real issues are and challenges are around rural health. And finally, we have to look with fresh eyes at what resources are available for rural health, and change the way we look at resourcing of rural health. Finance is obviously critical. Funds is also obviously critical, but there are other things as well. So let me finish just by saying what I said at the start. The one thing we shouldn't forget and that we shouldn't give up on is that access to healthcare services is a constitutional right. Constitutional is the supreme law of this country. Without health, there can be no dignity. Without health, there can be no equality. So pushing on health and health equity is central to everything that transformation and nation building in South Africa is about. And thank you. I'll stop there.